All right, welcome everybody to tonight's event. How are you, Dr. Barnett?
I'm great. How are you? It's so great
Good.
to be
Well,
here.
it's good to have you. Welcome back to Woo You. You are a Woo You favorite, so we're happy to have you tonight.
So happy to be here.
Let's get started. So welcome to Are You Ready to Conquer Keratoconus? Management of Keratoconus Update with Dr. Melissa Barnett. I'm your host, Dr. Jennifer Stewart, and thank you to Metro Optics for exhibiting at tonight's event. Just some reminders, there is no QR code for tonight's event. To receive your CE certificate, please fill the survey. The link will be emailed to you when the event concludes. Attendees must be online for a minimum of 50 minutes for credit. Your certificate will be sent by email and reported to ARBO with your OE tracker information. Please allow up to 4 weeks for certificates to be emailed. Please ask questions throughout the presentation. We'll have time at the end, so you can use the Q&A on the right-hand side of the page. Handouts can also be found there. To minimize, use the down arrow, and to open, use the chat button. So welcome again, Dr. Barnett. We're happy to have you back here at Woo You. She's a world-renowned key opinion leader recognized for her expertise in dry eye disease, specialty in scleral lenses, keratoconus, and presbyopia. She's authored more than 300 articles and books, delivered over 500 lectures, is a board member and founding member of the Intrepid Eye Society, and serves on several industry boards. She's the author and editor of Specialty Contact Lenses and Contemporary Scleral Lenses Theory and Application. Her work has been featured in medical journals, professional magazines, as well as consumer publications such as the Washington Post, Bloomberg, Prevention Magazine, and Good Housekeeping. She's an associate certified coach credentialed by the International Coaching Federation. She specializes in mindful leadership, wellness, and effective communication, empowering individuals to become their best selves in both their personal and professional lives. She's energized by her passion for helping people improve their lives by optimizing their vision, health, and wellness with a customized approach. She's most proud of being awarded the EB Game Changers Award from Eye Care Business, the Legends Award from the AOA CLCS, the Scleral Lens Practitioner of the Year, the inaugural Thea Award for Excellence for Mentoring by Women in Optometry, and was granted the most influential women in optical by Vision Monday. She's the host of the Clearly KC and Starting Strong podcast and advocates for elevating eye care throughout technology and her influence on the profession. So welcome. It's so great to have you here. Here are her financial disclosures. And with that, I am turning it over to you, and I'll see you at the end.
Awesome. Awesome. Well, thank you so much for having me. I always enjoy being here at Woo You. And thank you all for joining. I'm so impressed that we have so many people here tonight to learn more about keratoconus. And really, we are all learning together. It's been amazing, all of the new developments in keratoconus and other things in eye care as well. So, this is me. And I will share a little bit about the Clearly KC podcast. That is a podcast with the National Keratoconus Foundation. And the podcast is for patients and practitioners. And this podcast has now been going on for several years. And it is my gift to the world that I didn't even realize how much of a gift it has been for myself. So, patients have reached out, especially saying how they listen to the podcast from other patients who are on it or other practitioners, and it really has changed their lives in such a positive way. So, if you haven't
Dr.
listened,
Dr.
yep,
Barnett, can I interrupt for 1 minute? We
yes.
can't see your slides.
Oh, no. Okay. Thank you so
You're
much.
welcome.
So thank you. Yeah, and now let's see. Can you see them now?
Yes.
Okay, can you see a
And
full screen?
I see caution steep hill ahead, managing keratoconus.
Awesome.
So you're off and
Appreciate.
running.
Oh
You're
no. Oh my goodness. Okay,
okay.
how's that?
You're good. All right. Now I'll
Okay,
see you at the end.
awesome. Okay, thank you so much for telling me that. So clearly, Casey, take a listen. It's when with NKCF. And if anything goes awry, please let me know and I'll fix it. So let's talk about keratoconus and let's talk about keratoconus in practice. So I am in clinical practice. I am also a professional life coach. I'm coaching as well. But I really want you to take away, if there's anything you can take away, it's to always be thinking about keratoconus and your differential for every patient. And you don't need to have any fancy technology, but we're going to go over things to identify keratoconus. And keratoconus is far more common than we knew before. And we'll go over some studies and all that too. So we know that the classic keratoconus definition is abnormal topography. If you have topography in your practice, fantastic. If you have tomography, great. That's fantastic as well. But if you don't, it's okay. We want to look at corneal curvatures, those who have steep corneal curvatures. And I also like to look at asymmetry in corneal curvatures. There's an abnormal posterior shape. So you can use your anterior segment OCT, you can use corneal tomography, which I always find is just the best of the best to really pull out the changes in the posterior cornea to diagnose keratoconus. But you can look at other things as well. There is an abnormal corneal thickness. We want to check global pachymetry, the entire cornea, and we can have corneal thinning as well. So, according to the 2015 Global Consensus on Keratoconus and ectatic disease, we need a few different things. So, the abnormal posterior ectasia, abnormal corneal thickness distribution, again, that's global, whole entire cornea, and the non-inflammatory corneal thinning. So here you can see a normal stroma. I always like to think of it like an apple pie for whatever reason. And there's natural cross-linking that occurs over time. So all of us, as we age, I never say age or old to my patients, but as we age, our corneas become naturally cross-linked or thicker from being outside in sunlight and things like that. So here you can see the cross-linking of a normal stroma. And in keratoconus, we have a lot of different changes. So we have focal weaknesses, and here you can see a beautiful image of the asymmetry in the cornea. But this is what I really like to see. So we can see the normal eye, and then we can see the eye that has keratoconus. And you can see the difference between the two here and how the normal eye responds and the eye diagnosed with keratoconus there at the bottom. Just it's more, it's not as stiff, it's more loose. I like to say, in the response. So we can use corneal topography, we can look at OCT, corneal tomography, and even if you don't have these technologies in your practice, we can look at a change in refractive error. Is there a change in astigmatism, an increase in astigmatism, new astigmatism? A change, one of my favorites is looking at an autorefraction compared to your subjective refraction. And if there's a difference, that makes me think, oh, there's keratoconus. So those are a few of the things. Retinoscopy is definitely your friend. Using retinoscopy to look for the scissors reflex, you can diagnose keratoconus. And also just asking questions too, asking questions of your patients. So we all heard, or many of us, it depends when you graduated, but years ago, it was previously estimated 1 in 2,000. So this was 1986 in the US, but we'll go over several studies, and keratoconus is actually far more prevalent. So that's why, if there's one thing I want you to take away, it's every single patient to be thinking about keratoconus just like we think about dry eye, and diagnose keratoconus so we can treat keratoconus earlier to really prevent any vision loss and save vision. So this is old news here. 1 in 5 people with keratoconus will need a corneal transplant. The reason I keep it in here is because if you have patients and you talk to them about keratoconus and they look it up, they can get very scared and frightened that, oh no, I need a corneal transplant. I'm going to lose my vision. I'm going to go blind. I'm going to die, and all these things. So that's why it's very important that we educate our patients. And there are some great resources, for example, from the National Keratoconus Foundation, that we can share with our patients to let them know that keratoconus is actually more common than you think. And here are various resources and treatment options. Steph Curry has been diagnosed with keratoconus. I'm not his doctor. I get that asked a lot. I'm in Northern California. I'm in Davis, but he's in the Bay Area, so we're a few hours apart. But I will highlight the National Keratoconus Foundation because when I have patients and they say, "Wow, I've never even heard what is this word kerato what? I don't even understand." And please, the National Keratoconus Foundation, they do have a warm line where patients can actually call and talk to a real human. There are patient support groups. There are booklets, brochures, and handouts you can give your patients and their family members. And it's a really wonderful resource. So let's look at some studies here. This was a meta-analysis, so 29 articles in 15 countries looking at the prevalence of keratoconus, 1.38 per 1,000, and in studies reporting a sex prevalence of keratoconus, men 20.6 per 1,000, women 18.33 per 1,000. I'll share a funny story with you. I had a patient and he said, "Guess what? Guess what?" And I said, "What?" He said, "Only men have keratoconus." And I said, "Oh, that's interesting." And I always like to rely on studies. It's like, that's not what the studies say. But in this case, I said, "That's really interesting because half of my patients in the waiting room today are women who also have keratoconus." So men and women can have it. And here are a bunch of studies. You don't have to memorize anything, but with the advancements in corneal imaging, with the advancements in corneal topography, imaging the front part of the cornea, and then corneal tomography, imaging the posterior cornea, we really can pick up keratoconus far earlier than we ever could before. So I'll share this study here from 2020 looking at the global meta-analysis, 0.14%, 1 in 700. And then another study here, 1 in 375. And let's share a new study. So this was the IKA, the International Keratoconus Association, which is just a wonderful group. If you're interested in keratoconus, it's a wonderful group to join. If you're interested in being on the podcast, the Clearly KC podcast, let me know. I would be happy to host you as well. And I'm very proud of my colleagues for doing this study, many of my colleagues and friends who analyzed corneal tomography, so imaging using the posterior cornea in Black and Latinx children in the Chicago area. So this study included over 2,000 children aged 3 to 18 in the Chicago public schools to look at the frequency of keratoconus and evaluated the variability by age and race. This was a prospective observational study using corneal tomography. So there are 4 key topography measurements: the Bellin-Ambrosia enhanced ectatic display, the BAD-D, looking at the superior to inferior ratio, looking at the thinnest point asymmetry, and Ambrosia's relative thickness index. So this is looking at a wide variety of pediatric patients from the Chicago area, from schools, and doing corneal tomography on every single one. So in this study, they used the final D values and the backed elevation at its thinnest point, and just some definitions. So those who did not have keratoconus, the final diopter was less than 2 diopters for both eyes. Those who were determined suspects for keratoconus had the diopters between 2 and 3. And those who were diagnosed with keratoconus had greater than 3 diopters. And those who had myopia, 18 microns, and those who had hyperopia, 28 microns, looking at the BETP. So in this study, 6 patients were diagnosed with keratoconus. So that was a prevalence of 1 in 334. 3 patients were classified as suspects for keratoconus, 1 in 669. So this was a total prevalence of 1 in 223. So this is really an excellent study that was done, and it teaches us that, wow, we should really be evaluating every single patient. Maybe there's There could even be more patients in your practice than 123 who have keratoconus or are a suspect for keratoconus. Okay, let me know if hopefully you can hear this.
Juggling too many credits and not enough shelves for all her hope, driven to do good, but missing morning classes and meaningful moments. Keratoconus came slowly and invisibly, so I never sought a cause beyond my own flaws. I assumed I'd burned out or messed up, struggling with depression and anger I'd never known before. I'd changed somehow, and was ashamed to admit out loud that I didn't know what was happening anymore. People stopped recognizing me. I stopped recognizing me. Defensive and aggressive, I rebelled against the person I wanted to be. So when they asked me why, I'd have an excuse for leaving myself behind. I closed one eye to read the screen. The settings must be wrong because I can't read a thing. I switched sides, black and white, the letters and the problem visible in detail. And that's when the tears fell. That's when I realized it was my eyes. Without my ever noticing, keratoconus had altered the way I walked and talked, the way I experienced time, space, motion, and interaction. As my cornea changed, so did the frame through which I received my whole world. It disrupted my dreams and put my life on pause, distracted, pained, and embarrassed me, shifting my focus and blurring what I primed to be the best years of my life. Hindsight is 2020, but I can't even tell you how much money I'd pay to get back my graduation day, my friends from college, the family I hurt on the way, the confidence I'm only now acknowledging went away when I blamed myself for things that weren't my fault. 2 years and too many lenses later, I carry supplies with the rest of the baggage I have yet to unpack. But the explanation proves I'm not broken. The condition is treatable, and I more closely resemble Rachel than I thought I would again. A vibrant young woman whose blue eyes smile when she realizes she can actually see again, including every trace of a laugh line that now grows across her face. It humbled me, robbing me of what I thought were my advantages. It exposed strengths I never knew I had. Making me feel foreign in my own life, it taught me to see through new lenses. I learned to listen in ways I hadn't, and empathize in ways I couldn't before. Obscuring my connection with others, it forced me to look internally for perspective. I'm re-engaging and reinvesting, knowing the truest friends see who you are, even when you can't. I'm stronger now, less likely to take for granted my health and wealth of opportunity. I'm still learning, but I've learned to be still, to love who I am and live with open eyes, mind, and heart. From what I can see, things look pretty good.
So I share this with you. This is Rachel Dungan, and she won the award from the National Keratoconus Foundation. And with permission, she allowed me to share this with all of you. She has keratoconus. She's also in her work in public health, working with people who have keratoconus. And I was very fortunate to be able to work together with her and lecture together in an IKA meeting. She's also on the podcast as well. So my goal to share that is really to stress how important the diagnosis of keratoconus is. I'm going to go through a lot of the diagnosis because we're going to get into the management here, but other conditions we want to look at are things like allergy, atopy, asthma, collagen vascular disorders, diabetes, mitral valve prolapse. Every single person who has Down syndrome needs to be evaluated and imaged for keratoconus. Any history of eye rubbing, and we know that's the really vigorous eye rubbing, not just the gentle eye rubbing, eczema, floppy eyelid syndrome, so really pulling up that upper lid when having the patient close their eyes behind the slit lamp. And pregnancy is also one where we do want to be evaluating our patients and looking for a change. So just some studies here, Down syndrome, 622% increased risk, so always evaluate for Casey. If you're bored or you want to spend a lot of time looking up, does Michael Phelps have Marfan syndrome? That you could spend hours of your life. But of interest, Abraham Lincoln did have Marfan syndrome. So interesting there. eye rubbing. And, is it the chicken or the egg? This question always comes up. Is it the eye rubbing that causes KC, or is it the KC that causes eye rubbing? But in a case control study looking at 280 people with keratoconus, eye rubbing was present in 83%. So one thing that we can counsel everyone is don't rub your eyes. And cool is your friend. So cool compresses, we can add in mast cell stabilizer, antihistamines, you can refrigerate them. You can refrigerate the artificial tears as well. This is a really interesting study looking at the association between sleep apnea and KC. And with severe sleep apnea, we know that the risk of death is up to 2 times higher than those without KC. So we want to evaluate our patients. And I ask them a very simple question, and that is, do you have any trouble sleeping? Oh, yeah, I get up all the time. I have a lot of trouble sleeping. And then I send them for a sleep study that can be with their primary care doctor. And that it's amazing how often sleep apnea is diagnosed and actually how common it is as well. So, use of a CPAP machine with severe disease can really improve the quality of life for those with KC. High drops is present in 5% of people with KC, and the prevalence of mitral valve prolapse is 65% in patients with high drops. So if you have a patient who has high drops, please be evaluating for mitral valve prolapse. We know about the genetic component. So every single individual who has KC, we want to screen their families. So their families, their kids, their relatives, everyone. And unfortunately, at this point in time, we don't have a genetic test that I know of, but we did have one before, and that was really helpful to know the risk factors or the risk level for KC. Hopefully that will come back at some point in time. Pediatric KC. The one thing I want to stress here is that pediatric KC is so much more aggressive than those in adults. So I saw a kid today. I saw her a few months ago. I seen her back for a follow-up. Never had an eye exam. At the school screening, she failed. She had 4 diopters of SIL in one eye and 3.5 diopters of SIL in the other eye, and with a Ks of 48 or so. And so we're working currently on the workup right now to get a pentacam for her to see if it's just regular astigmatism that is picked up now and she's 6 years old, or is it keratoconus? So fortunately, we're going through that. And fortunately, she was screened in the schools and they caught that. So they did a really great job. But we know that pediatric KC is far more aggressive. We can have 8-year-olds who have vision loss, even younger. And so we really want to detect it early and asking the questions like, is there any history of eye rubbing or allergies? And this is really helpful to diagnose keratoconus sooner so that we can treat it. This is one of my favorite studies that when I lecture in person, I can see people say, wow, I don't even know. I didn't even know about that. But pregnancy and KC. So there are changes, lots of changes in pregnancy due to hormones, and there are changes in the biomechanical properties of the cornea, and it can change its refractive power. So this is a study looking at 22 patients with bilateral keratoconus. 11 intended to get pregnant, 11 did not intend to get pregnant, and looked at the refractive and topographic data before pregnancy, during the 3rd trimester, and 6 months postpartum. All eyes in the pregnancy group experienced significant progression in KC, and none of the control eyes demonstrated disease progression. And also, there was no reversal after pregnancy, so people's corneas did not go back to where they are. Now, there's no follow-up data. It's a very small sample size, but my takeaways from this is if someone is on maybe a suspect for keratoconus, really to get imaging, get corneal tomography, image that posterior cornea, do anterior segment OCT, diagnose KC, and if possible, cross-link the cornea prior to pregnancy, if possible, of course, not during pregnancy, and to prevent the progression. And also to inform our patients that if there are vision changes, to come back to after pregnancy. I'm skipping one of my favorite studies in the interest of time there. These are things I do not recommend. I do not recommend telling your patients to smoke because there was a reduced prevalence in KC with smoking. And I do not recommend to inform your patients about poor diet to get diabetes. But I'm sharing these studies with you because you might see this in practice. And once I learned these studies, I started looking at my patients who had diabetes, who were smokers, and discovered, wow, their keratoconus was not as advanced as those who did not. But again, not my recommendations at all. There's a huge economic impact of keratoconus, and there's a huge quality of life impact with the diagnosis of keratoconus. So, my goal for you sharing this information is to really be empathetic when we're talking to our patients because there are clinical visit fees with contact lenses. We know that there's the lenses and the materials and the fittings, and even just the cost of going to appointments, traveling, not working, perhaps having a family member or friend or relative bring them to the appointment. Maybe it's the cost of that person as well being unable to work. So it is a very large burden. And there can be a significant cost to the entire healthcare system as well, which is why we want to diagnose and treat sooner rather than later. Here's this is from NKCF. The patients pay more than $25,000 for the cost of care over a lifetime. And I think on the right, this 46% of patients pay more than $1,000 annually for treatment costs. That number can go up significantly more if you think of maybe a lost lens or which happens over time or travel concerns and things like that. There are so many different studies looking at the quality of life in people with KC. This is one study. This was a prospective study over 1,000 patients for 7 years and showed that KC is associated with a significantly impaired quality of life that contributes to decline over time. So again, we want to be there to support our patients, to help them, to give them options. And there can be a variety of options that we're going to go over, but really to address their keratoconus and to listen to their journey. Because many times I see patients who have gone to 4 other doctors first, and then they get to me. And we need to listen to our patient's journey. And sometimes that takes a while, and that's okay. Sometimes a visit, a tip you could do if this works in your practice is to have a conversation if there is a very complicated history, not just for KC, but for other things as well, and find out, for example, what worked and what didn't work. Were there scleral lenses that were tried and they didn't work? Did a patient have cross-linking and it was not successful? Whatever it might be. Or did they have a corneal transplant and need visual correction afterwards? So many different studies here. Okay, let's look at corneal topography in KC. So on the left, you can see a normal cornea. Next to that, you can see the form frest. So that is someone where we would not want to do certain types of corneal refractive surgery. Then in the middle, we can see a nipple cone, and then an oval cone, and then globus. So the entire cornea is steep. And these are some really beautiful, nice topographies, but this is not necessarily real life because everyone's cornea is different. Okay, so years ago, we used to think, let's diagnose, we can monitor, give visual correction with contact lenses or glasses, and then need a transplant. But fortunately, now we have so many new technologies where we can diagnose early. We stop progression with corneal cross-linking and then rehabilitate vision with a variety of options. So this has been a huge game changer here in the US since 2016 when cross-linking was FDA approved. We do want to monitor often. I think that's really important. So if you're unsure, for example, if the person has keratoconus, maybe they're a suspect for keratoconus, you can always see them back, and you can see them back sooner rather than later. What do I mean by that? If you're not too worried, you can see them back in 6 months. If you're very concerned, you can see them back in a few weeks or a month. And if it's somewhere in between, of course, 3 or 4 months. But we do want to monitor anyone who has a corneal transplant. We always want to monitor. I like to monitor every 6 months or even more frequently. So let's talk about cross-linking, which is exciting times in cross-linking, approved in the US in 2016, and really revolutionary in the treatment of keratoconus. So there are several randomized controlled studies. So I'm going to go over cross-linking and the progression from when it was first approved to just this week with some new exciting news. So when cross-linking was first approved, and I'm actually going to just kind of go on here to the procedure. So the procedure, like we saw earlier with the corneal stroma, the apple pie, should probably stop talking about apple pie. Some of us on the West Coast have not had dinner yet. Some of you on the East Coast, maybe you should have some apple pie. On the right-hand side, we can see that there's less cross-linking, and then at the bottom, we can see more cross-linking. So the primary indications back when cross-linking was first approved was progressive, that's very important, progressive KC, and any sort of corneal ectasia. So the procedure was epithelium off, so removing the corneal epithelium, applying riboflavin UV light, and needing a minimum corneal thickness of 400 microns. What does progressive mean? Well, we learned it means all sorts of things with different insurances. So it could be a half diopter more astigmatism, increase in corneal curvature, etc. Cross-linking is really unique how it uses UV light and riboflavin B2 drops, and it creates new corneal collagen crosslinks and results in a shortening and thickening of those fibrils and leads to stiffening of the cornea. So it's not necessarily a refractive procedure. So then iLink was approved. This was 8 pages, patients who were age 14 to 65 were in the FDA studies. And of course, cross-linking is not indicated during pregnancy. So here you can see the procedure, thanks to my friend Mitch Eibach for this great video. And this is the epithelium being removed for cross-linking. And I'm just going to show you, it's kind of a time-intensive procedure. And when the epithelium is removed, and it's drops, UV light. And look, she looks so happy having cross-linking done. Isn't that exciting? So here's sort of the procedure. And again, this is the initial procedure that I'm talking about. So looking at the health economics and health costs. So what I want you to take away here is that there's a reduction in the lifetime costs of over $43,000 with cross-linking. There's a huge reduction in costs of not needing a corneal transplant and all the risks that are associated with that. And so it's a US national savings of $150 million per year, with conservative estimates of 1 in 2,000. And now say it's 736 million with a prevalence of 1 in 375. And if our prevalence is actually higher, that number goes up as well. Fortunately, cross-linking is approved in many different states. The coverage is much better than it was before. So now let's move on to the next FDA approval, and this is epoxia. So this was approved last year. The first procedures were done just this past March in 2026. And this is an intact corneal epithelium with UV delivery. And this is an oxygen supplement, and it's different oxygen supplement compared to some other cross-linking that is done. So I'm talking about what we have here in the US. So this was commercially available. The first procedures are being done currently. Now, what I will share here that's really important is, one is epithelium on. So this eliminates the pain associated with the removal of the epithelium, really streamlines the procedure. It minimizes recovery. And it is based off of the two formulations, so Epoxia HD and Epoxia, that are sequentially administered. And so we have cross-linking, UV activation, and the special oxygen goggles. But what I want you to see here is that you don't see the word progressive or progression or anything like that. So that is not indicated in the FDA label. So it could be anyone who is diagnosed with keratoconus, adults and pediatric patients greater than 13 years were in the studies. And a corneal thickness can be 325 microns, which is lower than the epithelium off version. And the boost goggles are used with this procedure as well. So the key point here is that progression is not included. So now I'm moving on. This is not yet FDA approved, but this is going to come soon. This is by the company Epi-On, and Epi Smart treats keratoconus at all stages. So I'm going to share a little bit about Epi Smart clinical technology. It's based on the diagnosis of keratoconus, not progression. So no need to demonstrate progression. You can diagnose keratoconus, and the epithelium is on, hence the name Epi-On. So all the diagnosis things that we were talking about, if you asking the questions as well, when we diagnose with an abnormal posterior corneal surface, and then we can perform Epi-On cross-linking. I'll say check with your state to see if that's possible for optometrists in your different states. So an applicator is used. A loading sponge is specially designed to maintain the drug concentration during stromal loading. The drug is applied, so this is riboflavin and sodium iodine, preservative-free, and then the device is used with optimal light cycling for the treatment. The phase 2 results, more than 80% of patients were stable or had improved vision at 12 months. So here you can see those in group 1 who all had improved vision, stable or improved, and cross-linking is not necessarily a refractive procedure. It's not necessarily like refractive surgery, but there was stability of vision and stability of the corneas and improved vision at 12 months. So here you can see all of the adverse events. Those who had an epithelial defect, 1.4%, MGD, 0.7%. You can see the adverse events here, and all the rates are under 2%. The cross-linking, the preparation, it's less than a minute. The riboflavin is done, 20 to 25 minutes, evaluate with slit lamp, and then the photoreaction about 20 minutes. So about 50 minutes, I'll say an hour, from start to finish for both eyes. So here you can see the chemistry. But what I want to share with you just recently, just 3 days ago, is that Epi-On announced that completed phase 3 clinical program for Epi Smart Epithelium On cross-linking. This is public information. You can go ahead and read about it. And this is exciting. Again, not yet FDA approved, but exciting to be coming soon. Okay, let's move on and talk about corneal transplantation. So, and you probably have patients still who have full thickness or penetrating keratoplasty. The most common question that comes up here is, can I fit a scleral lens if there are sutures? Yes, you can. If a suture is removed, I recommend that you have a good relationship with your corneal specialist and your patient to tell you when a suture has been removed, because that can significantly change the amount of astigmatism, like 6 diopters and things like that. But yes, it's safe to fit a scleral lens. But now we have so many different technologies. So we have technologies for corneal transplants that really address the area of the cornea. So for example, the limbal epithelial stem cell transplantation, or if we just want to address the descemetous membrane, we can do a posterior lamellar or endothelial keratoplasty. If it's a stromal issue, it's a deep anterior lamellar keratoplasty. So it's much more targeted. We work with excellent surgeons who do a great job addressing the different types of corneal transplants. However, we know that there are always risks involved with corneal transplants, which is why we want to monitor our patients. And the graft and the endothelial cell count will decrease over time. Here you can see some studies that have been done. So we want to monitor closely, many times using long-term steroids, topical steroids, and we want to be checking at all times for the risk of any sort of graft rejection or reaction. Those that are at higher risk are those who have vascularization. So here on the upper right, you can see the vascularized cornea, any history of a previous rejection, any history of herpetic or ocular surface disease are at higher risk. Those that are at lower risk, those who do not have vascularization, and endothelial rejection is the most common. So here you can see this really nice cotidose line, thanks to my colleague, Dr. Karina Koppen, for this beautiful image here. But there is a long-term risk and a lifelong risk of rejection, which is why we want to monitor our patients very closely. So a hint to inform your patients and to advise them to be seen immediately if there's any redness, if there's any photophobia, if there's any pain or decreased vision, to come in right away, because many of these people have neurotrophic keratitis. They don't have any sensation. So we want to let them know if their eye gets red, or if someone looks at them and their eye gets red, they need to be coming in immediately. Now, this is new developments in corneal management, CTAC, which is corneal tissue addition keratoplasty. This is a minimally invasive anterior lamellar keratoplasty, which augments the corneal shape. And what I really like about this is it helps both uncorrected visual acuity and best corrected visual acuity, because we know that many people who have keratoconus want to, say, see to have a glass of water in the middle of the night. And so it's really nice to have improved uncorrected visual acuity as well. This treats mild to severe cases. There's no age limits. CTAC can significantly improve vision. So you can look at some studies here. In uncorrected vision, about 6 lines improvement of vision. In spectacle corrected vision, 3.5 lines of improved vision as well. So the tissue dimensions of CTAC are very customized for the patient, and it's based on corneal tomography. It's incredible how customized and how much refractive error they can provide. Here you can see 20 diopters, 29.9 diopters. Wow. So here are some images, post-op, pre-op, and the difference, looking, say, at the bottom one, a moderate 5 diopter change, but that can significantly improve someone's quality of life. Who is a good candidate for CTAC? So ideal is the max, the Kmax, so the steep cornea in the central 6 millimeters, a Kmax of 50 to 80, greater than 300 microns in the thinnest area of the cornea, and a best corrected spectacle vision of 20/25 or so. A poor candidate would be pellucid marginal degeneration, so where we have inferior steepening, that kissing bird sign, where we have really dense scarring in the central region, or dense central scarring. But here you can see an ideal corneal topography and not ideal. And I would encourage you to talk to your corneal specialists in your local area. So many more are offering CTAC every month, and talk to them to see if they're offering this technology for your patients. Okay, so moving on to the next technology, we have scleral lenses, which are large diameter gas permeable lenses. Go over the cornea, land on that scleral conjunctiva. They are not new. Scleral lenses are actually the first type of contact lens that was developed, made from PMMA material, originally made with an impression, and now made with really high decay materials, very reproducible, sophisticated designs, multifocals, and we have many different indications. So those who have irregular corneas, like keratoconus, those who have ocular surface disease, and those for the correction of refractive error. And I am going over the indications here because I believe we all need to know the indications for scleral lenses, and it's okay if you don't fit them in your practice, but please refer to a colleague who does. So all these indications, also any sort of irregularity after refractive surgery, post-LASIK, post-PRK, post-RK, any sort of corneal scar, trauma, elevation on the cornea like Salzmann's nodular degeneration. Some of my favorite indications are those who have severe dry eye disease, those that have autoimmune related dry eye like Sjogren's or lupus, rheumatoid arthritis, those that have Steven Johnson or graft versus host disease, any sort of exposure, even missing an eyelid or things like that, any sort of persistent epithelial defect, all candidates for scleral lenses. Also, limbal stem cell deficiency, those patients who abuse their contact lenses, maybe sleep in them, who have the pannus, neovascularization superiorly, oftentimes, or any sort of neovascularization with other lens designs, or those who've worn corneal GPs and they fly off the eyes. Contraindications are any sort of cornea that has a reduced endothelial cell count, so we want to check specular microscopy to look at that. Fuchs corneal dystrophy, they're highly debated, is glaucoma. Many studies showing that scleral lenses are fine for glaucoma and IOP is stable. And now we're also looking, of course, at optic nerve OCTs and visual fields over time. But we do want to be checking intraocular pressure in those who wear scleral lenses. So the most common way is removing lens, checking pressure, which is not actually the true pressure. Here you can see in the middle pneumotonometry, and that can be checking IOP with the scleral lens on the eye. So we have great technologies now. The scleral lens fitting has changed so much in the last 20 years. We have customized instrumentation. So instead of having every single fitting set in the world, we can use technology to make our process much easier. This is a great study looking at scleral shape from Greg Denayer and the Scleral Lens Study Group, showing that most eyes are not completely spherical. Actually, only 5.7% of eyes. Most have require back surface toricity in the scleral lens. And therefore, primary categories of scleral shape. Fortunately, we have so many different diagnostic scleral lenses that include back surface toricity. So here you can see, this is one of my favorite studies I'm going to share because you can take this study and put it into clinical practice. And corneal and scleral toricity are not necessarily correlated. So you're not going to have a with the rule cornea and then a with the rule sclera, for example. But in those looking at healthy eyes with minimal astigmatism, in high astigmatism, the sclera is more irregular if the cornea is irregular. So if you have someone who has advanced keratoconus, then think when you're fitting scleral lenses, I need to apply more sophisticated designs in the scleral toricity because it's probably going to be more irregular as well. Here are some profilometry devices that are available. They're all wonderful. They take many, many data points. They've really revolutionized scleral lens fitting. We still need to put a lens on the eye and evaluate it. But the technologies, many of them work with specific companies that you can select a first fit lens and put the lens on the eye, and they're very, very helpful. There are many different educational resources that are available on scleral lenses. There are many different articles, and this is a resource where you can click on each link, and specifically for keratoconus, but many of the links are still relevant, and there are books and guides and videos that can help you. Feel free to reach out to me if you have any questions about any of these. I will encourage you, all of you who fit scleral lenses, to be a member of the Scleral Lens Education Society. There's a wonderful video that you can share widely with your practice on your website, share it with your patients. And we do know that scleral lens handling is more complicated than handling rigid lenses. So 63% in scleral lens wearers, 40% in rigid lens wearers. Giving your patients resources, super helpful. Here's one of them from AOCLE. We also have the Scleral Lens Society with the resource. So giving your patients written information is quite helpful, giving them videos, giving them references of where to look if they can't find that information. And we do really want to review handling, because we could have a lens that's ideally fit, it's perfectly fit, great vision, great comfort. And if your patient can't handle the lens, they're not going to wear it. Fortunately, there are many helpers that help with handling. There are more and more each year, which is wonderful. And your patients might be really creative. I know that my patients are. They create their own little devices and helpers, but reviewing handling is so, so important. We have many different options. And I want to go over solutions here, because solutions are so important when we're talking about scleral lenses. So using a preservative-free solution, replacing that disposing of the solution of the vial that's preservative-free after single use, because we don't want to have any risk of infection at all. There are different solutions. Some are buffered, some are not buffered. And there are some new solutions coming soon, which I'm very excited about. Disinfection, very important. So we want to be cleaning our scleral lenses. We want to be manually rubbing and also using a multi-purpose solution. There are various multi-purpose solutions, or a hydrogen peroxide-based solution. Again, new disinfection solutions are coming soon, which I'm excited about. Okay, I think I'm going to come back to that if we have time. We might not. We're just having so much fun. Okay, corneal GPs. Corneal GPs are so important. I like to think about all of our lenses for keratoconus as tools in the toolbox. Corneal GPs are one of the most helpful tools, because we have great vision, we have great tear exchange. As far as price, it's less costly than a scleral lens. And the materials and the designs are so advanced. For those who have had corneal transplants, I especially love a certain corneal GP lens design. It works so incredibly well. But we can have really good vision, really good comfort with these technologies. We have prolate designs, oblate designs, just like scleral lenses. And we can see in keratoconus, we can have different diameters, so we can customize the optic zone. All of this, they're super, super helpful. So we want to evaluate the cone and see where the steepening is. How large is it? Is it a nipple cone? Is it really small? Is it really large, like globus? And that's going to really determine what lens we decide to fit. So I'm going to share one thing that's coming right up here for corneal GPs. It's just when we're fitting the lens, we want to start with the central apical fit. We want this light feather touch. And here you can see the bearing on the top one, the clearance with the bubble in the middle, and the 3-point touch on the bottom. And using diagnostic fitting, there's also empirical fitting that we can do now for corneal GPs as well. And this is an interesting one, looking at comfort and peripheral clearance. So I learned from this study is the minimal acceptable is up top. The average is in the middle, looking at peripheral clearance, but highly acceptable, so more comfortable lens is at the bottom, where we have even more clearance. And that looks like actually quite a bit of clearance to me. So when we're fitting, I'm now fitting corneal GPs differently based off of this study. So work with your lab. The consultants for all these lenses are really excellent, and they can be very helpful. Don't forget about piggyback lenses, where we can use a soft lens and then a corneal GP over, so that can help stabilize the corneal GP lens. The soft lens can be used to protect the cornea, improve comfort for someone who doesn't have a comfortable GP lens. We also have custom soft lenses, and there are a variety of custom soft lenses. And I'm continuously impressed how good the vision is with a custom soft lens. Here are lenses. So again, talk to your lab that you're using, see what lens is available. You don't have to have every one, but for some people, this is very, very helpful. We also have hybrid lenses, which have a rigid center and a soft skirt, and these can be designed empirically now. So just taking the information from your topography and your keratometry and having anterior segment OCT here is very helpful when fitting these lenses, but they can provide really great vision, really great comfort, especially when there's not severe dry eye and ocular surface disease. So as we wrap up here, I'm going to share this with you. This is the technical report, guidelines for handling of multi-patient contact lenses in the clinical setting. So say if you're fitting a scleral lens or a corneal GP and using it on more than one patient, to disinfect it, we do want to place 3% hydrogen peroxide in a non-neutralizing or flat case. We want to disinfect for 3 hours, rinse the lens with multi-purpose solution. This study you can download. You can use this reference here on the right-hand side. You can use it in your practice. And you can also use this for how to document all of the lenses as well. It gives really good guidance. So I want to thank you for improving lives and saving vision by diagnosing Casey earlier, by managing it earlier, and really helping our patients along the way. So with that, I'm going to open it up for questions.
Thank you very much. That was fantastic. So let's see, we've got some questions coming in. So we have a few minutes, so feel free to get those questions in. When can a patient start fitting scleral lenses after cross-linking?
Yeah. Oh, great. This is one of my favorites. So before 2016, we had patients go off to different countries and get cross-linked and then come back. And so they're wearing scleral lenses. I didn't even know they went to a different country and then came back. And so what we learned from that in our practice was, wow, they can actually start like 2 weeks after and be completely fine. So there's some really nice studies looking at protocols. So you can start fitting a patient before cross-linking with a scleral lens, have cross-linking done. Of course, it depends on if it's epithelium off or epithelium on cross-linking. And then even with epi off, just a few weeks later, they can successfully wear their scleral lenses. And if you train them beforehand, that's a really helpful hint because then they know how to go over handling and they already have that down.
What's the recovery like after cross-linking? How do you talk to patients about recovery and what they need to do after cross-linking?
Sure. So in epi-off, we could use a bandage lens and using drops, and it's very, very different depending on the type of cross-linking that's done. So epi-on, it's completely different. They can go back to normal functions. So epi-off, I'd say take the day after off and just rest and relax. But it's amazing that it's pretty fine. Like patients do pretty well. Not everyone, it depends on the individual person, but just counseling them that if it's epithelium off, it's going to be a process a little bit. If it's epi on, it's a very, very quick recovery.
Can you share what corneal GP you like for post-transplant patients? And the follow-up is, are we not concerned about furthering corneal thinning in this case due to corneal touch?
Yeah, so I'm not going to say any specific brand names, but I'll say it's an oblate lens design. So it's flatter in the central, steeper in the periphery in a corneal GP lens. And so you can ask your laboratory manufacturer if they have that. I'm sure they do. And then I learned from Lynette Johns that all corneas after corneal transplants are unique. They're like snowflakes. And so some corneas do need a prolate lens design, but I find that one specific oblate lens design works really well. It's a little bit larger in diameter for corneal GP. And then, sorry, what was the second question about thinning?
Are we not concerned about furthering corneal thinning if there's corneal touch?
Oh yes, so I'm not fitting the lenses with corneal touch at all in a scleral nor a corneal GP. But I will say for those who have had corneal transplants that we do need to evaluate the corneal endothelium. So doing specular microscopy, especially if we're fitting scleral lenses, and with corneal lenses, we do have more tear exchange, which is another advantage there.
Perfect. Well, with that, I want to thank everybody for attending, and thank you, Dr. Barnett, for once again sharing your wisdom. You're fantastic, and we can't wait to hear you back again. We're getting lots of thank yous in the chat, so
Oh, thank you. Thank you
everyone
all
saying
for
thank
coming.
you.
I'm so pleased with the attendance. And if any of you are going to Phoenix for AOA, please come say hi. I would love to see you.
So thank you for everyone attending. Stay tuned for a chance to win a complimentary fitting set of your own. Thank you to Metro Optics for sponsoring tonight's event. Make sure to stay tuned and hear more about contact lens options for keratoconus patients with Lauren Seisler. And the number one question that's always asked, no QR code for tonight's event. How will I get my credit? Your certificate will be emailed to you within 2 to 4 weeks. The certificate can be uploaded to your account for credit, and WooU will also provide Arvo with your attendance. So don't worry about that. And thank you everyone for attending. And now let's hear some more.